We are live.
Good afternoon, everybody. It's a pleasure to invite you and welcome you to this particular special myopia progression control module. And at the outset, I would like to thank our scientific committee chairman, Dr. Namrata ma'am, for giving us this opportunity to start a purely dedicated module on myopia progression control. I would just start by, and she's currently on a flight, but she has been kind enough to share this video of hers. We'll go through this. Yeah.
Everyone, I welcome you all to this course, which is on myopia management. This is going to be in 11 modules, and we are running the first module today. And I'm thankful to Dr. Chaitanya for being the chief coordinator for this course. This is a certified course, so after you finish all the modules, you would also have to do the questions. And once these questions are answered to our satisfaction, certificate for the same would be given. So I would like to thank Dr. Chaitanya Jethani, all the speakers, the panelists, as well as all the delegates who joined for this course. Thank you, ma'am.
So thank you so much, ma'am, for this wonderful webinar for everybody. And I think this would enable more and more people to learn and understand the nuances of myopia progression and how to control the myopia progression. So we have with us a very eminent panel of experts. Dr. Love has joined from Calcutta, despite his extremely busy schedule. He is already, I think, at the airport. Dr. Love. Ramesh also has kindly. Yeah. So Dr. Ramesh has also joined us right now. And I think Dr. Rohit will join soon, and Dr. Siddharth also from Mumbai. So we have two great pediatric ophthalmologists as moderators, Dr. Anand, who's a dear friend and a colleague, and Dr. Ajinka Deshmukh. So over to you, Dr. Anand. You can go ahead and
Good afternoon, everyone. First of all, very happy Republic Day. Thank you, Dr. Namrata Sharma and Dr. Jitendra Jethani, to put up such a fabulous module on management of myopia. So, as you all are aware, myopia has not only now remained a simple refractive error, but it has turned into a significant public health challenge, particularly in children and young adults. This session on the management of myopia will take us through evidence-based strategies, real-world challenges, and practical approaches relevant to our clinical practices, especially in India. To that end, we have an excellent panel of speakers who will help us translate current science into meaningful action for our patients. So to begin with this session, I invite Dr. Pavan Varchicharla, who would be speaking on myopia problem statement, incidence, and prevalence. Over to you, Dr. Pavan.
Thanks, Dr. Anand. I will share my slides. Okay. Can you please confirm that you can see me and you can see my slides as well?
Yes, we can see your slides and you're loud and clear.
Great. Thank you so much. Very good afternoon and very happy Republic Day to one and all who has joined today. And thanks to AIOS and Dr. Jethani for inviting me to speak on this certification course on management of myopia. These are my financial disclosures, and this talk is not intended to endorse any product, but to promote science. The outline of my talk is as is on the screen. I've got 4 parts. Firstly, we will go through why myopia is called as a disease at this juncture and some of the definitions in relation to the myopia. And the part 3 goes to indicate about the myopia prevalence and the myopia incidence. And at the end, I will conclude by showing some of our research studies on indicating what are the challenges. So to start with, I think the problem statement is the myopia we call today as a disease. Is it really a disease? Do we really believe that myopia is a disease? One of the famous statements that comes out is once a myope is a lifetime myope. We all believe that, okay, somebody has -3 during the childhood clearly is going to live with -3 or more than that during the course of the life, unless they undergo LASIK. That's a different ballgame. But once a myope is a lifetime myope is a appropriate statement. Now, to call anything as a disease seems like classification need to be met. First of all, is it a biological dysfunction? Does it involve deviation from normal physiological structure or function? Yes. Clinical manifestation, do you see a recognizable symptoms or measurable markers? Does that condition or an entity affect the quality of life? And does this entity require the interventions or monitoring or something to as a prophylaxis to control the management, to control the problem? We have multiple myopia control options, and there is a debate about should we label this as a disease. I think without any hesitation, we would label this as a disease because myopia meets all these 4 criteria. Number one, yes, there is a deviation, there is an eyeball elongation, structures are affected, and these are largely permanent. You're talking about chorioretinal atrophy, lattice degenerations. There is clinical manifestation, there are measurable markers. We say axial length, choroidal thickness as a potential markers to understand the progression. The quality of life is affected in individuals with high myopia compared to those with non-myopes or maybe low myopes. And definitely there is an evidence to say multiple myopia control options are available, and we need to look at every diopter. The definitions are a little confusing, or people have used this interchangeably in the recent years. Therefore, I thought I will bring it up in few slides. Myopia correction, myopia control, and myopia management. At times, these are used interchangeably, but these are extremely different because myopia correction, as the name itself indicates, we are talking about correcting the optical focusing error. That's it. Nothing to do with control, nothing to do with providing any intended benefits in relation to the progression. We don't talk about progression. You have an error, you correct it, therefore that's the correction. Now, control, on the other hand, is a next version where we look at correction along with adding evidence-based intervention intended to slow the progression of myopia and axial elongation. This is essential component of myopia management, involves the monitoring. Whoever you are, be it ophthalmologist or optometrist, I think single agenda worldwide east to west is to ensure the eyeball does not grow any further, and this can be achieved through one of the evidence-based intervention. Myopia management is an umbrella or a comprehensive term which takes care of myopia correction, myopia control, pre-myopia, prevention, early detection, controlling, and the management of the complications as well. So therefore, I want to call it as an umbrella term. What we should be doing is, I think, is myopia management, but not really myopia correction or control, because it encompasses various entities of myopia. If you ask me for myopia management, is there an evidence? Yes, there is enough evidence, multiple papers. On the right side, you are seeing the evidence from the Living Systematic Review that we published last year, indicating that various myopia control options actually work in children in controlling the progression. So we'll switch to the myopia trends. What's happening in Indian scenario? I mean, before we go Indian, 1 out of 2 children to have myopia in the global arena. The same numbers stand true for Indian standards as well, or the Indian scenario as well. For 2050 prediction, it indicates that about 48% of children living in the urban regions of India to develop myopia. Again, 1 out of 2 individual. As of 2020, 2025, in urban regions, we are looking at 25% of myopia here. But is there a difference between rural and the urban regions? Yes, in the rural regions, the prevalence of myopia is less than 10%, but in the urban regions, we see touching 30%. There is also a difference between the private schools and the public schools. Private schools showing relatively higher prevalence compared to that of the public schools. So private schools, even if they are in the rural region, as you see in this picture here, the prevalence of myopia indicated by blue bars is higher compared to the public schools. In urban regions as well, if somebody is going to the public schools, the prevalence is little lower. Now, this figure that we've drawn using the data published by Agarwal et al. In 2020, multiple papers, rural versus urban. In rural regions also, there is slight increase in prevalence. But in urban regions, you see all the way from 2012 to 2026 today, I think there is a drastic increase in the prevalence of myopia. So this is the data that I was talking about, forest plot, nicely indicating myopia prevalence in the rural and the urban regions, clearly on the rise if you compare in the last 4 decades. Myopia incidence, I couldn't find a lot of evidence coming out from India, and this paper published by Saxena et al. A few years ago shows that myopia incidence, meaning new cases of myopia, every year hovering about 3 to 4% in younger ones compared to the older ones. So if somebody is less than 9 years of age, we are looking at about 3 to 4.7% new cases of myopia. So overall, there is increase in prevalence of myopia. What is also important for us to note is in Indian scenario, children progress by about half a unit every year, and 20% undergo rapid myopia progression. 20% of children undergo rapid. When I say rapid, I'm talking about 1 diopter or more. And pathologic myopia complications are about 4% of myopes to have some sort of retinal lesions. The problem, I see this as, who are these myopes? Who are these myopes that are having to have myopia? Who are these myopes having myopia progression? Clearly not everybody. Only 1 out of 5 individuals are showing rapid myopia progression, and only 4% to have retinal. Unfortunately, we do not know who are these 4% of myopes to have retinal lesions. So putting it in the numbers, global scenario and Indian scenario, I think pretty much on same boat. High myopia is on rise, and therefore the worry. The hidden impact is there is psychological stress that the child undergoes. There are job opportunities that goes down. Quality of life is affected. And therefore we say we need timely intervention. But timely intervention, does it happen always? And who are the stakeholders for not doing the timely intervention? I think there are challenges at 3 levels. Myopia practitioners, myopia students. I mean, today's students are tomorrow practitioners, be it ophthals, be it optoms. I think if they are undergoing this training, if they are not up to the mark, then we are not providing adequate education for them. Parents, who are another stakeholders, who should be aware of what are myopia control options. So this is cross-sectional questionnaire-based study. 343 responses were obtained. I will quickly run through this. To highlight, we asked, what myopia control strategies do you know? 33% of them indicated undercorrection, which is surprising. Single vision spectacles are still considered by 53% of the students, and this is again a surprise, which is not great. What myopia control contact lens do they know? Everybody felt, not everybody, 37% reported single vision, 19% again reported single vision rigid contact lens. So clearly we are not up to the mark. Now, if you look at awareness among the parents, we asked, do you think myopia can lead to vision related complications? Either maybe or no. You see that about 45% of them felt that, okay, this is not a problem. Do you think progression can be controlled? Again, 50% of them felt that it cannot be controlled. Do you think early myopia progression is important? This is good. Some of them felt it can be done, but still sizable proportion says that early treatment is not so important. Which myopia control treatment are they aware of? I am not aware of. Stood out in more than 60% of the parents. Now, we did a survey among the optometrists and the ophthalmologists and also added trainees as well. And they've all indicated that lack of education and training was the barrier for them to practice myopia. I hope sessions like this will help. But unfortunately, at this juncture, we are looking at only 1 out of 5 practitioners involved in myopia management. So flipping those numbers, 33% students still prefer under correction. Most of the parents, more than 50% of parents unaware of myopia control treatment. 80% of practitioners put put the ophthalmologist and the optometrist together, still practice single vision as a treatment. So there's a big problem. I think number one, myopia does not, one size does not fit all. All myopes are not the same. There are refractive myopes, there are axial myopes. Overall, we say myopia is on rise and we need some solutions there. All myopes are not axial myopes, and clearly not everybody progress as well. Even if they are axial myopes, 20% approximately progress. It's important that we pick them instead of shooting in the dark. As a researcher, I think there is a need for contributions from the India standpoint, given that myopia is multifactorial, risks are not the same. Unfortunately, we know very little or nil about myopia in spite of centuries work of research. So there's no single cause. Where there are good news is there is myopia control treatment. The myopia management options are available. Site of action is very different. A lot of times we do not know where it is actually acting. But unfortunately, at times we shoot in the dark. One size does not fit all. So one treatment does not fit all as well. Personalized treatment, I think, is the way forward. So overall, there are multiple problems which, as an eye care practitioner or an eye care researcher, the onus is on to tackle this problem. With this, I thank you for your attention.
Thank you, Dr. Pawan. That was a very comprehensive talk, clearly laying down the problem statement for myopia and also laying down the background for the rest of the session. Before
Thanks,
we
Dr.
let you go, we would like you to highlight, on behalf of the audience, we would like you to highlight whether the numbers in India are following the trend that was seen in East Asian countries like China and Hong Kong. If yes, probably the genetic and the environmental factors are similar. And can we do something so as not to follow the same curve?
Right. I think the trend looks similar, the trajectory, what was seen in the East Asia maybe 20 years ago. We are not there yet, but if we leave as is, I think the trends are going to go up. Is it genetics or environment? I think largely the blame is on the environment because genetics to cause such a rapid rise, it takes a lot of time. So it could be screen time, more near work, strive for academic excellence, multiple factors. But I think the trajectory is similar to East Asia.
Do we have Dr. Rohit Saxena?
No, I don't think he has joined.
No, he's not there, sir.
We can.
Okay. Any of the expert panelists
Dr.
could
Ramesh.
probably Dr. Ramesh or Dr. Love, Dr. Siddharth.
Dr. Ramesh is there.
Yeah. Yeah, I think Pawan has explained everything. It's just that everywhere people ask the same question. Is India in the same scenario as any time in the East? We are not yet in terms of magnitude. But the population is so high that even if there is a shift of 2% per year, there is a significant number of children who are going to come. So obviously we have a rural and urban divide. Whichever school screening and everything you take, everywhere there is an increase in the number. Just a caution I just want to say is that the across the world, the myopia every year addition of children are increasing. That is, I'm talking about school myopia, not that early onset or syndromic myopia is. It's not the point. So, and also, people are thinking any kind of myopia or any kind of astigmatism, some kind of anti-myopia therapy works. This is something we have to be very careful because when you treat, it is that axial myopia where there is myopia correction, myopia control, and myopia management. So this myopia control applies to the axial. So that's something we need to. And yes, in 2025, I think everybody who has a myopia, the parents and the children, they need counseling from the ophthalmologist or optometrist that there is some treatment, because not giving any kind of treatment maybe at this stage is unethical. That's why Pawan has showed that what is the awareness among optometrists and ophthalmologists and also parents. It's our duty to really say and come up with this kind of advice for the parents.
I just had a question whether, whether we
Yes,
really.
those were very interesting. Yeah.
Yeah, Dr. Jitendra, you had a question.
Yeah, I was
Pawan?
just trying to ask whether, Ramesh, whether we really
Go
see
ahead, Jitu bhai.
whether we really see the prevalence or rather the incidence going up. Like, is it because of the awareness or truly the numbers are on the rise?
Yeah, I would say the numbers is not alarming at this point of time where the number is going like that. But if you look at the projection, we are talking about another 25 years, right? If that projection. Like each year, even if you add 1% additional patient, it's a lot. That I think definitely we are seeing, the best picture what we will get is from the school screening program. It's not that school screening fails in, if you screen 100 patients, probably 10 or 12 fail. Out of that, it's not a significant number. It's that year on year number which adds will be a projection at this point of time. We know it. Probably, I think, I don't know, in the next 5 years, our school program might change. Even somebody like Andhra Pradesh is already coming up, right? No screen or social media till 16 years, something like that. If it changes, probably you might have our school program might change a little bit. We don't know. That way, the projection wise, I think even if you add 1% per year, in the next 25%, it'll be a 25% increase. That's what I think we can project it.
I think just to add, in one of the slides, I've shown multiple data points of these various studies. The way data is collected also plays a role. Yes, somebody might be doing only a visual acuity based cutoff, but now you have auto refractors based on, do you say 0.25 or do you want to go 0.5? Then the numbers will fluctuate. But in general, yes, the myopia I think is increasing, but based on the type of method that you use, you will show a variable prevalence value.
Yeah.
Also,
Okay.
I would be interested in knowing from Dr. Pawan and probably the other experts, is the incidence and prevalence of myopia on the increase in rural areas too, especially with the urbanization taking place over there?
Yeah, I think good question,
Do we have
Dr. Anand.
some data on that?
Yeah. So I think overall, definitely in the urban regions, the increase looks much more startling, very evident. In the rural regions, it's not like the urban regions, but in the rural regions, if they're going to the private schools, I think, like you said, there is urbanization. They in those specific cohorts, you see little increase. Compared to rural urban, I think urban definitely stands high in terms of showing higher myopia prevalence. Rural are picking if they are in that specific risk factor zones, such as private schools. I'm sorry, I'm using the word risk factor zone for the private school, but yeah.
Yeah, I think there are already studies from eastern part of our world. The schools which have private versus government, schools which are in urban versus in rural, already there is a significant difference.
Yeah.
As a clinician, we practice in Hyderabad and we go to sometimes to a secondary center in a rural area. When you look at the electronic medical record of these places, or when we go, children coming for myopia treatment or things are really less. I think there is a Chennai based rural as well as urban. They have done, even at Teleprasad, we have done a Krishna district, the entire school children, close to 1 lakh. It is, we have screened. It is definitely less. So, more urbanization, chances are more, probably related to multiple things. As Pawan said, it may not be just environmental, it's a school program, and also some kind of genetic things also will be there. So, yes, at this point of time, I see a clear difference in the urban and rural area in India.
Thank you, everyone. So I think with that, we'll move on to the next speaker. Can I request Dr. Ajay
Yeah.
here to introduce the second speaker?
Yeah. Thank you, Dr. Anand. First of all, thank you, AIOS Scientific Committee and Dr. Jethani for giving me this opportunity. It is indeed a very well thought certification course. Taking it further from what Dr. KR was mentioning, and also I'm very grateful that I'm getting to share the platform with my mentor, Dr. KR. So, what Dr. KR just mentioned, that not as a healthcare practitioner, as an eye care practitioner, as an optometrist or an ophthalmologist, not seeing a case of myopia progression and not suggesting any intervention is unethical. And also it is becoming medico-legal. If you have seen in recent times in news, there was a news that that parents sued a doctor for not suggesting myopia control intervention. So indeed, it is a very well thought certification course for that matter for all the ophthalmologists who see myopic kids in their OPD. So Dr. Pawan had already given us the incidence, prevalence, and the problem statement. Going ahead with our second speaker, Dr. Neelam Pawar. She is trained at Arvind Eye Hospital, Tirunelveli, and practicing. And she will be talking on natural history of myopia progression. Over to you, Dr. Neelam. Dr. Neelam?
Yeah,
Can you
yeah.
please share your screen? Yeah.
Yeah. Slides are visible?
Yeah. Slides are visible. You are audible. Can you be a little louder, please?
Yeah, sure. Yeah, so at the outset, I would like to thank AI Scientific Committee, Dr. Jiten Jethani, for taking time to organize really this wonderful modules for the myopia awareness. So I will be speaking on natural history for myopia progression. So as you know, we are in digital era. The books have become like a museum in shelf and empty parks and hands having digital gadgets. So no wonder Asia is becoming a hotspot in myopia, and we are seeing increasing prevalence in both developing and developed countries. So as Pawan has already mentioned about the rise in myopia and increased prevalence, and all of us are well aware of this Holden chart that by 2050, 50% of population will be myopic. A recent publication also estimates that that around 740 million children and adolescents will be myopic by 50, and there was also a commentary on this paper. Like really we don't know the exact number by 2050 what will happen. So myopia is a hot research topic everywhere, and in pediatric ophthalmology, if you see, it is the most cited articles are on myopia. This is the recent publication by Langis et al. In which they described about from 33,000 papers of myopia. They gave a table of 10 most cited articles in the field of myopia, and all the papers talking about etiology, epidemiology, pathogenesis of myopia. And the last list, if we see, it was from Elie Dolgin, and who is a basic scientist, and I had opportunity to interact with him in 2024, and he took a short interview of me, and whatever 1 hour interview he narrowed down into 4 lines. And what Dr. KR said, I also said to him that really we don't know the prevalence of myopia by 2050. Holden et al. Have said it 50%. It will double. We don't know whether it will be double or triple. Really, the exact numbers we don't know. And after talking and discussing with him, really I was impressed that as a clinician, as a surgeon, and as in field of ophthalmology, we think different. But whenever a scientist away from ophthalmology, if they write something about myopia, really they are more concerned about the prevention and science behind the prevention of myopia. And he, in his one paper in which was published in Nature, first article published in Nature about myopia boom, he mentioned about Dr. Henry Enward. And Dr. Henry Enward was in 1904. He was practicing, and almost a century back he wrote this book in which there is a chapter on refractive error. And if you go through this book, he simply describes about how the eye elongates whenever a child stoops his neck, whenever a child is reading close to book, how the rectice, the vessels are getting enlarged, and how the tunics of the eye are getting enlarged and leading to axial myopia. And in his book he mentioned about the progressive myopia, that if you want to decrease the progressive myopia, take your child to a long sea voyage away from all the books. And really has given all the points which we in our daily practice we use as a behavioral modifications as a treatment to myopia patient. So does the progression matters? Yes, each diopter matters, and the work done by Bullimore and Philcraft, they have given a nice tables, which is a standard, and we will see this table in all papers, that all presentations, that each diopter increase in myopia is associated with increased lifetime risk of 67% in prevalence of myopic maculopathy, 30% in RG, and 20% in prevalence of glaucoma. And we see with the rise of myopia, though the increase is just in terms of -2 diopter, but the prevalence of all the risk of all the complication really goes exponentially very high. So slowing a myopia by 1 diopter should reduce the likelihood of patient developing myopic maculopathy by 40%, and therefore each diopter matters. Myopia, as we know, it is a complex, we can call it as a condition, some people call it as a condition, and or it is a complex disease with a multitude of factors involving the interplay of genetic, environmental, microenvironmental components, or combination of all these. And as we see in a normal eye how it grows at birth, the mean axial length is around 16 to 17 millimeter. K is very high, and after the birth the axial length increases, and this mean K decreases with sharp decrease in the dioptric power of the lens. And this is the famous curve by Jordan and Don, which shows that in initial first year of life there is a rapid increase in the axial length, which gets stabilized slightly by 3 to 4 years, and by 5 to 6 years of the age the eye is at its emetropic level. So there are 3 phases of eye growth: a rapid postnasal phase, an infantile phase, and a slow juvenile phases. So again, a paper, this was published in Survey of Ophthalmology in 2022, and it nicely described that how a biologic normal distribution Gaussian curve changes to a leptokurtotic distribution by age of 6. Like at the birth, this distribution is quite normal, but then there is a shifting to a negatively, it is a skewed deviation. So why this skewing happens? So this is because of emetropization, because this active regulatory process harmonizes the expansion of the eye along with the optical power of the cornea and the crystalline lens. So all 3 are playing role in the emetropization, and myopia is considered as a failure of homeostasis. Whenever there is full emetropization, there is no refractive error, but whenever there is a homeostatic failure, refractive error can result because of primary homeostatic failure, or an eye can become emetropic, but later it fails to remain so during the subsequent years, leading to a secondary homeostatic failure. And therefore we have, including the childhood myopia, we see myopes in early adulthood, late adulthood also, and then there are so many factors because of all this emetropization, why we get fast and slow progressor also. So in initial ages up to 12 to 13 years of age, there is sharp decrease in the dioptric power of the lens. And as Pawan mentioned, we always deal with 2 types of myopia: axial myopia in respect with axial length, and then refractive myopia, in which we take consideration of refractive power of the cornea and crystalline lens also. So myopia, as all of us we are discussing, it is a complex interaction of the retinal, optical and environmental factors. All of us, we know that the strong stimulus is the peripheral hyperopic defocus, which causes the enlargement of the axial length, and along with this hyperopic defocus, our circadian rhythm, our sleep duration, time to get up from bed, all this affects myopia, and there's lot research going on in sleep and myopia, and also in the higher order aberration and light spectrum. So in experimental setting, the form deprivation and lens induced defocus have already, there are so many studies which shows that this form deprivation and lens induced defocus, they are actually responsible for the axial length increase because of hyperopic defocus. And in this experimental, because of all these experimental settings, only IMI has come to the model of the visually regulated control of eye growth and refractive state, that whenever there is a visual signal in the form of hyperopic defocus, the retina and RP cells, they undergo a biochemical changes, a series of changes, and we know dopamine is one of the most widely neurotransmitter involved in this, and all these changes are then they give signal, there is a signaling cascade to the choroid, then the changes happen in thickness of the choroid, which ultimately gives to extracellular matrix remodeling, leading to changes in thickness of the fibrous and cartilaginous sclera, ultimately leading to high axial length and changes in the vitreous chamber depth. So these are all the experimental things that from the stimulus ultimately to the scleral expansion or increase in scleral changes and expansion in the axial length of the eye, and it is even histologically proven. And all this experiment, if you see all these experiments, you will see very nice pictures of all these chicks, mice having defocus lenses. So the accommodation role with the STAMP studies, it has shown that really we don't know whether accommodation really plays a role in the myopia and progression. And then higher order aberrations which are in our surrounding, they are also potential myopogenic stimulus. There is a recent concept that very bright colors and high correlated color temperature can also give rise to myopia development and progression, and low spatial frequency of environment is also related to the development of myopia. And as we have discussed, as the eye grows, there is flattening of the cornea, and lens is also getting thinner and thinner. So failure of this process of emmetroprization leads to myopia, and if we talk in terms of AL by CR ratio, the axial length is increasing, the cornea is not able to flatten, so thus it is steep, and therefore we get, and only the lens is getting emmetroprized, that is lens is only getting thin, so we get a high AL by CR ratio, which explain in most of the studies, it explains the variance in the spherical equivalent, which is more than the axial length, and most of the studies, even in the later adulthood and in young children, they have shown that more than 3 axial length by corneal curvature ratio. In myopes, we see this ratio. So these are the biometry changes in the myopia, AL by CR, which is more correlated, and it is having more variance to spherical equivalent. The lens is initially becoming thin and flat up to the age of 14 to 15 year, and later on again it started increasing in thickness, and it is only because of the refractive changes going on in lenses. And also vitreous chamber, also some studies have shown that it accounts for over the 50% of the observed variation in spherical equivalent refraction. So there is always an interplay between nature and nurture, and whenever we are having this is generation R studies, again a landmark study with a birth cohort of Netherlands children, and it has evaluated everything, the gene interactions, and they have proved that both the nature and nurture are equally important in the myopia, and even the ALCR is correlated to the increase in the myopia. And even right now with the GAUSS studies and 23 Me's genetic studies, we are having AL by CR ratio for almost all the age group less than 10 years, 10 to 25 years, and more than 25 years. So with every ALCR, there is a genetic loci behind it. And then these are all the studies, population-based studies, which tells about the time spent outdoors. Unfortunately, in India, we are not having any long-term study regarding to time spent outdoor and the progression of myopia, and therefore we have to always see on the other population-based studies. So another landmark population-based study is COMET, which is correction of the myopia evaluation trial, and it showed that younger children, they are having the fastest progression, and progression was not dependent on sex, and it was dependent on ethnicity. And among all the myopic children of 6 to 7, 8, 9, 10 and 11 years, a 0.5 millimeter increase in axial length was associated with 1 diopter of myopia progression. And these same children who progressed to high myopia, children who developed myopia earlier, who were younger and who had more myopia at baseline and having 2 more myopic parents, were progressed more towards the high myopia. Pawan et al., Pawan and their group had this paper on myopia progression, in which they have included all the ages, and it is a 1 year progression of myopia, and they have found the similar thing, that our progression is somewhat similar to Chinese ethnicity. So with these 2 landmark paper, we get to know that younger age at baseline is the strongest independent factor associated with faster myopic progression. East Asian myopic children have more axial length elongation compared to European children, and in non-myope study, axial elongation of more than 0.20 millimeter per year could be used as a simple indicator to screen and monitor, and these cases may show a higher progression and greater risk of myopia onset. So even with our natural course of myopia, a drastic change can happen. So whenever 2 epidemics collide, COVID-19 and myopia, we saw a surge in myopia, and that's why I think the 20 by 50 predictions will really change. And digital devices, we are keep on seeing, these are the 3 meta-analysis. First meta-analysis was done in in early 2017 or 18. That time there were hardly 5 or 6 studies. They show that digital devices can be a risk later on in 19 a paper came, it said that there is again a mixed effect, and children because of digital device can develop myopia, and in 2025 we are having a proper high odds ratio that 1 hour of, see, all the systematic review really they are highly evidenced thing, and this recent paper showed that 1 hour of daily screen exposure gives a 21% higher odds of myopia. So these are the excellent trajectories. Usually, just like our height and weight of the children, we track down this excel length, and even in adult with high myopia there can be changes, and this paper shows that there are 3 phases in adults with high myopia, that at even after age of 25 also there can be increase in myopia. There's only one paper by Gopal Krishnan et al. From the STEM study which tells about this growth curves exit length by ALCR ratio, that it increased in from grade 1 to grade 6, and after going through all this progression when this myopia stabilizes. So seeing this COMET study again, it showed that the age at which myopia stabilized was around 15 to 16 years, 15.61 with a standard deviation of 4.17, and a recent study in the UK cohort also showed, which is the DREAM study, it also showed that myopia do get stabilized at around 19 to 21 years. So whether the recent concept is whether to see this progression, whether the centile curves are important, but this paper by Bullimore and last year in Arvo also, they emphasized more on the age annualized growth curve compared to the centile curves. And yes, we have to, whenever we are seeing the efficacy of any treatment, we have to always see whether there is a progression with intervention and how is the physiological emetropic growth and progression without intervention. Currently we are having a myriads of biometer device which are for doing the to see the excellent progression in myopia cases. One has to be only cautious that all these instruments are very good, but they should not be interchangeable, and whenever you are making any decision, it should be always on the same instrument. And we are having this myopia master, and really it gives a very beautiful track of excellent progression in the children. This case, why I kept just to show that myopia, it is always not the same, each and every case is different. This case I am observing since 3 years, and every time the machine is giving same exit length, though the both parents are myopic. So really the mystery of myopia lies with myopia only. And right now there are so many things going with AI also. This paper we presented in last year in RO, and it tells us that uncorrected, what we got that in our hospital cohort, that uncorrected visual acuity and exit length by corneal curvature in most of the ensemble methods, they were the main predictors to estimate the spherical equivalent. And what we saw was the biometric markers, but behind this and beyond this biometric markers, our fundus is also having all the signs of the progression. So we have to always see how is your choroid. There are so many things going on, choroid vascular index, about parapapillary atrophy, about vasculometrics, angle, and branching angle and angulation and vessel calibers of vein and artery, and fundus tessellation density, both parapapillary and macular. So much things are going on, so we have to look beyond this biometry parameters also. So to conclude, that every myopic eye is myopic in its own way, and really in India we are not having much long-term studies, so we can tell about the natural course of progression of myopia. So really we require more studies which will give us better understanding. And thank you for patiently listening.
Thank you, Dr. Neelam. It was a very well researched and very comprehensive talk on the natural history of myopia progression. It is indeed very important for everyone to understand the natural history, how the myopia onset starts the typically school myopia, how it progresses, and who are the rapid progressors, who are the slow progressors, what are the risk factors. So, and when especially in now when we are talking about every diopter matters, so it is very critical for us to know this natural progression and know if one child is crossing that natural progression and is at risk of having fast progression, and to decide on the intervention appropriately. So I would want to ask the panelists, in your experience or in your practice, what are your cutoffs when you plan for myopia control intervention? Uh, do you have a different criteria for a younger cohort, maybe less than 10 years and more than 10 years, considering the progression is relatively slower in those who are about 10 or 12 years of age, and a bit faster below 10 years of age? Dr. KR, Dr. Rohit, Dr. Love.
Yeah. There are two things, Ajinkya, and great talk, Neelam. First thing is high risk characteristics, and the second thing is the types of progresses: mild, moderate, and severe. So for the high risk characteristics, I always take three into consideration, three factors. One is the child per se, second thing is the parents, and third thing is the where the environment the child is growing up, be it increased screen time or less outdoor activities, the way the child reads, what is the screen time or reading in a sleep position, the lightings, all that. That's an external factor. And the immediate risk factor which gives me is the parental myopia. If they are -1, -2, I don't worry. But parents and the siblings are really high myopes, not even moderate, then that is a red flag for me. And when the child comes to you, there are some child factors, right? If a child is -2 at 2.5 years, that's a red flag sign for me in the absence of any retinal dystrophy or anything. Because early onset myopia, I always rule out syndromic as well as retinal dystrophy because they can have it. So if they have it, that is a rapid progressors. In all of this, if the child comes at around 8 year or 9 year or menarchal age, probably they will be on the high risk factor because natural history has a different curve when the child attains menarche and things like that. So suddenly sometime there could be a shoot. So for me, three factors for high risk or risk categorization: child factor, environmental factor, and the parents. Second thing is whether it is a rapid progressor, mild, or very slow progressor. And I never start anything when the child, when the child is start progressing only, I will put some anti-myopia factors. So anti-myopia treatment. So these are the two things I consider, Ajinkya, in my practice. Just to on a, you need to have 6 or 7 questions to reach this in your busy clinic.
Thank you, Dr. KR. And how about the objective measures like axial length cutoffs versus the spherical equivalent or the spherical power for that matter? What usually is the deciding factor in the usual clinics? Do we actually look into the millimeters of or no 0.1 millimeter of axial length elongation or a spherical equivalent increasing by 0.5 or 0.25? That matter.
Yeah, for me, axial length is what we target, but there are some other exceptions to that. Maybe Jitendra can answer this question rather than me only answering it.
So what I do is, for me, axial length would definitely tell you that this patient would would progress. So axial length does, if the axial length progression is more than 0.2 or 0.3 millimeters, it does tell you that this patient is bound to progress. So some of the patients would come up to you where their SER or spherical equivalent has not really progressed, but axial length has indeed progressed. And so these patients, that some compensation is going on, and it is not in some time you would see that these patients would progress when they come back to you in the follow-up after 3 or 4 months. So I keep axial length, as Ramesh said, I keep axial length as a more robust, more objective data. But at the same time, you have to understand that subjectivity is very important, and patient doesn't, you can't change glasses if they have really not changed.
Correct.
So axial length does give you an objective as a biomarker, not biomarker, but as a investigative tool, that this particular patient is more likely to progress in near future. And so you can tell the parents that, this patient, the kid may progress, and they should be more aggressive in terms of environmental modifications, and probably they are not doing enough.
Correct. So taking it further from here, so in such cases where axial length is elongating and refraction is pretty much okay at this point of time, then in that case your choice of intervention would be probably pharmacological and not the optical, if I'm correct.
I think both optical and pharmacological would target the axial length only. So maybe their
Correct.
mode
No,
of
no, but because the power is stable, you would not want the patient to change the glasses in that sense.
True.
Then correct.
Yeah, so so there's a small issue with the glasses. The glasses, they get scratched very quickly. So normally within 6 to 8 months, if you see their glasses, they are in a pretty rough shape. So yes, you are right that if axial length is progressing, we would definitely would not like to go and get the same pair of glasses. But if it is so, you have to see the quality of glass also. But yes, you are right. We should try and add on or escalate the dose of low dose atropine, if that is what we are talking about.
Sure. How about the high myopes and pathological myopes? How do we seeing so many parameters or biomarkers, imaging markers? So routinely in clinical practice, how do we document and look into or follow up with these tools for those above -6 of myopia?
I think there are two things in this. Number one, that all these things would be taken up in module 2, which is on myopia documentation. But to answer the question, see, at the end of the day, whenever we talk about myopia, it is the progression part only that we can touch upon or treat upon. So the progression clearly is based on the glass power that is being progressed in last 6 months or last 1 year, and the axial length. The reason why we take other biometric readings are that we should be sure that other biometric readings are not getting affected, and we should be pretty sure that we are actually dealing with axial myopes and not dealing with something else. Syndromic myopes and ROP, retinopathy of prematurity, babies having myopia, obviously they have a different mechanism of progression and a different mechanism of myopia itself. So they don't really fall into the gamut of this school going myopia progression, the children who are affected by these particular myopia plants. So we don't really go for treating those syndromic babies having myopia with these the usual means of giving drops or using optical treatments for them. What do you say, Dr. Ramesh?
Yeah, I think the question Ajinkya asked is if somebody is, again, the question is depends upon what age, Ajinkya. If -6 or -8 at 3 years, I would be really worried to look into. I will search deeply for any kind of syndromic myopia or retinal, because there is a dictum, right? If the myopia is more than the age in years in a child, that's an indication. If 2 years old comes with -4 or -5, you have to search really hard for any kind of syndromic. But once you get that, typical school age starts at maybe around 5 years of age. They'll start with 0.5 or maybe 1, sometimes 2. Sometimes some of those kids will come to you at 9 years of age with -3. There, probably we can take. So sometimes the spherical equivalent, what happens is, if they have 1.5 astigmatism with 0.5 of spherical, when you really combine, the spherical looks really large. But what the child is having is a majorly an astigmatism component.
True.
I will not be aggressive in those patients. So that's why even in syndromic, if there is an axial elongation happening over a period of time, you can look into it. But the treatment option, I think we are discussing in the next modules. I don't want to combine everything here, I think.
Any more comments from other panelists, expert panels, Dr. Lau, Dr. Rohit, if he is there? Otherwise, we'll move ahead with the next talk, Dr. Anand.
Yeah, before we move on, there is a audience question for Dr. Neelam. Is there a sex predilection for progression? Like, did she find in any of these studies that the progression is more common in boys compared to girls? And secondly, she cited a couple of meta-analyses indicating that increased screen time is a big risk factor for progression. So is it the near work which is the main risk factor, or is it the electronic device which is causing the progression? So these two questions for Dr. Neelam Pawar.
Most of the studies, they say that female, because they are being more inside, they are more involved in academic activities, more orthodox, you can say. So most of the studies, they have found more progression in female patient. But as we see in Comet and NICER, like it is, at last it has not come as statistically significant. There is a mild increase in progression and mild increase in spherical equivalent, but it is not significant.
And regarding the second question, yeah.
The second question, it is, there are so many variables which they have seen in the meta-analysis. It is the type of gadgets, the light emitting from the gadgets, the near distance. So many things they have taken into account. But at last, what they have concluded in the recent article is the amount of work time. Because see, there are various studies. In the Netherlands, there's a study in Netherlands in which even in this NICER population, they have done with the app in which they have really calculated the distance from the book, and it is like it is so nice study that with each and every, like throughout the day, with that app they have seen. Otherwise, with most of the trackers, we don't know what it is recording, but with that NICER study, they have used the app and they have really given the hours, that how many hours a child is looking and how much near that child is looking.
All right, thanks a lot, Dr. Neelam. That was a great presentation on the natural progression of myopia. Now, understanding why only some children progress rapidly while the others remain stable is very important for effective myopia management. Now we have a lot of treatment for controlling myopia, but identifying the children who are at risk, when does the progression actually happen, and which factors are the most important ones, are what will truly guide our clinical decision. Our next speaker will address the risk factors for progression of myopia with insights that are highly relevant to our everyday practice, particularly in the Indian context. It is my pleasure to invite Dr. Niluparna Deori from Guwahati to deliver this talk on risk factors for progression of myopia. Over to you, Dr. Deori.
Thank you. Thank you so much, Dr. Anand. At the very outset, I would like to thank AIOS for the wonderful webinar, and my gratefulness to Dr. Jitendra Jethani sir for giving me this opportunity. So I'll share my screen now. Is it seen here?
Yes.
Yes, doctor. Can you just make it in slideshow mode, please?
Yes. I'm on the slideshow now. Is it visible?
All good, please.
Yes. Yes.
Thank you so much. So today I will be talking about the risk factors for progression of myopia. But before that, I would like to thank my previous speakers for making my job a little easier, because they have almost touched upon most of the important parameters while we discuss the risk factors for progression. I have no financial interest in this presentation. So as we see, when the worldwide epidemic of myopia was booming across the globe, we felt that we needed to look at the projections of the prevalence of myopia across the countries. So here you will see that although the projection from the Brian Holden studies shows that there is almost a 50% increase in the prevalence, will be an increase in the prevalence of myopia by 2050, but there is an uneven distribution of progression across the different continents. So you will see that the East Asian groups were having more of progression compared to the rest of the world. Now, because of that, there was an article which came up in early 2015, reported the myopic boom, and they felt that countries like Hong Kong, Taiwan, Singapore, and South Korea saw a rapid increase or an exponential increase in the prevalence over in the year 1940s to the 2000s. So why was this happening? So because we need to understand that as the myopia progresses, along with that, we'll have different reasons to worry about the complications that come with the progression of myopia, especially the ones who are in the severe myopia or the higher myopia category. So in order to address this, we need to understand that sometimes to identify the risk factors and embark upon the prevention of myopia, it is more important than at least the treatments. The prevention would be better than curing this situation. So we will be talking about mainly the axial myopia. Now the concern here was why? Because the bilateral myopic choroidal neovascularization is something which showed more than almost 30% increase in the category of children who were having pathological or severe high grade of myopia. Now, there are many factors that work in the emmetropisation of the eye, and when this emmetropisation fails, what could be the factors that will affect the growth of the eye to progress? So different variables like the genetic factor, parental history, or time spent outdoors, especially the sunlight effect, or the near work, or the use of gadgets during these times among the children, and also the pathogenesis of peripheral defocus in the progression of myopia has been studied. Now, when we talk about emmetropisation, we have actually gone through it in my previous lecture. Senior has already told about this, that when an infant, the infant eyeball is actually a hyperopic eyeball, and as it grows over, as the newborn grows with time, eyeball grows with time, there is interaction or among the different structures of the eyeball, especially the cornea, the lens, and the axial length, which actually matters, and the changes in the different structure to reach emmetropisation in adulthood. So if there is a go signal, that is, there is a hyperopic defocus, and the growth increases, it increases more. But if it is a myopic defocus, then there is a stop signal which says that the growth has to slow down and emmetropisation is attained at adulthood. Now this is done through various mechanisms where the retina, in the retina, the image is out of focus, and this sends a negative feedback signal to the RP or the choroid through various neurotransmitters like dopamine, GABA, retinoic acid, and nitric oxide. And further, they help in the remodeling of the sclera, where some other factors like MMP, TIMP, and TGF also helps in the remodeling and the growth of the eyeball. So as we see that in the newborn period, when the eye is hyperopic, it reaches its average of around +2 by 3 months of age. And by 9 months of age, this decreases to around your +1. But what happens after the child reaches an age of 3 years? And in that age, the child stays or stabilizes and has a plateau both in its growth up to the age of 6 years. But what happens drastically after the age of 6 years, that the eye slowly tends to diverge in the myopic category, and then slowly there is an increase in myopia. So Ma et al. Has described that the emmetrope or the hyperope almost remains same, but the myop, this category, tends to increase. Now, why does it happen is what we are trying to see, that why some children tend to become more myopic and some do not, given that they are in the same environment sometimes, or given that they have the same genetic predisposition. So the prediction of myopia in these children, in this graph, you will see that it is not necessarily that it is the age at 6 years that they will go into myopia, but the arrest in emmetropization or the divergence of myopia may occur at any age from 3 years onwards. So why this is important is because if the earlier onset of myopia is there, then there is an increase in the as the age is lower, there is an increase in the myopic shift towards as the age grows. So we have to address the situation in order to control the progression of myopia further in the teenage or the adulthood age group. So as I have told before, that why there was an uneven distribution in the East Asian population compared to the Caucasians, there are other factors. Could there be factors which, like for example, genetic factors or familial factors, which say that these children are more prone to develop myopia? So while trying to do that, there have been many genetic studies, especially the twin studies, which says that there was almost an 80% variation in those children who had were monozygotic. And the first identified myopia gene was MIP1 gene at exon 3, but they had a single haplotype at OPN1LW, OPN1MW in exon 3. And along with that, the NITS theory also looked at some of the cone functions, where they saw that there was a dysfunction in the L and M cone dysfunction. I will get to it later on. They had actually studied the color vision in the children, but then they came up with something which actually projected towards the myopia progression in children who had more of the ratio between the L and M cones were similar. Then comes the genomoid studies across all the populations, but this genomoid study had a variation of only 7.8%. So you can see that there is a discrepancy in the inheritance patterns in both the twin studies and the GWS studies, with many genetic variants of small effect influencing the retinal signaling, which we already spoke about. But there was a strong association with the GNB and the DRD1 gene, which is for the dopamine and the glutamate. Now, why we call myopia as a complex trait is because there are several genes for secondary syndromic myopia also, which will overlap with those of the common myopia, and it is sometimes difficult to identify them exactly, that this category of people will have myopia in the future generations, because sometimes even if the parents do have myopia, children do have myopia, but it is difficult to predict in the generations that are 2 or 3 generations beyond that, the one that we are testing. So the studies by Kurtz et al. And Saw, especially Saw et al., said that parental myopia history is significantly associated with the occurrence of myopia, but particularly so in cases of high myopia in children. And Kurtz et al. Reported that the progression over 5 years was minus 1.8 diopter among children in the single vision lens group with no myopia parents, compared with minus 2.59 in children with 2 myopic parents. And Saw et al. Reported that having 2 myopic parents added a minus 0.43 diopter every 6 months to the rate of myopia progression. So we can understand that along with the genetics or the epigenetics and the epigenetics, there were also other factors which supported that the environment could be another additional or additive effect in the progression of myopia. So then the association came with the outdoor activity. So Rose et al. Presented in his paper that higher levels of total time outdoors, spent outdoors, rather than sports per se, because indoor sports cannot be included here, were associated with less myopia and more hyperopic mean refraction after adjusting for near work, parental myopia, and ethnicity. So that means that the higher levels of total time spent outdoors were associated with less myopia. Now you see that the near work in these children, as the amount of outdoor time was increased, the near work, or even if the child was doing near work, he did not have a high correlation with the progression of myopia, especially in the age group of 12. So does this happen because of the light effects of the sun? And to study that, there were various experts who showed that the light, the effect of light on the dopaminergic receptors, especially the D1 and D2, had an effect whether the child will go into myopia or hyperopia in the mouse model. Zhu et al. Said that if the D2 receptors were increased more than the D1, then the child had a risk of progressing to myopia. So there was another research where they actually studied more extensively in the mouse model. But however, in the human model, how much it can be predicted is also a point of research. Children with, you see in this graph, you will be able to see that those children who had both parents myopic progressed to higher myopia towards the increased age group, but the chance of becoming myopia for children with no myopic parents appears lowest in children with the highest amount of sports and outdoor activity compared with those with two myopic parents. Therefore, even if you have myopic parents, your chances of having progression in the myopia will be reduced if the outdoor activities were increased. Therefore, it has been seen that in most of the studies, outdoor activity has been given an important role in the progression of myopia. Similarly, as we have discussed earlier regarding the urbanization and the rural or the private and the public schools, the effect of the study period in these children, we see that the education pressures have a causal role in relation to the myopic shift in refraction that underpin the phenomena of school myopia. And according to some studies, myopia is significantly associated with continuous reading, longer duration of reading, shorter distance of reading due to the promotion of eye growth by sustained accommodation. Therefore, the confirmation of causal link between exposures experienced within a school grade and myopic shifts in refraction, combined with the evidence that age per se has minimal impacts and has important implications. This means that even as the grades of these children grew, that is, as they were going into higher grades, the amount of time they were putting into their books or their educational work was more. Therefore, it really did not matter whether the child was a younger child or an older child, but the grade mattered in these children. So regarding the ethnicities, as we have discussed earlier, that why there was an uneven distribution. So could it be because these children were actually having a predilection to progression? So there were studies from the Chinese from the Chinese cohorts, and then the study by Cheng et al. They studied the population who had migrated, the Chinese population who had migrated to Canada, and tried to see whether the ethnicity really did play a role in the progression. So the ethnic Chinese children living in Canada developed myopia comparable in prevalence and magnitude to those living in the urban East Asian countries. So you can see in this graph. And the recent migration of children and their families to Canada actually did not appear to lower their myopia risks. So how did they find out? Even in their questionnaire, they found out that considering all the or negating all the factors like parental myopia or having the ethnicity or the amount of near work, they found that less outdoor activity was one of the consistent factors in the progression of myopia, even in children who actually shifted or migrated to a different country. So as I was talking about the L and M ratios, dysfunctional ratios, the NATES et al. Paper, which actually patented for the color vision defects and immetroposition in humans, they found that there was an additional finding where they said that the L and M ratio, if it was more, the L ratio was more to the M in the Caucasian age group, the amount of myopia progression was less as compared to the Asians who had an equal ratio of L and M. So you can see in this graph that the mean axial length elongation in Asians were more compared to those of the Caucasians if the ratio of the L and N opsins were equal. And then coming to the prediction in the juvenile onset myopia, authors like Carla et al. Said that the onset of myopia in childhood can be predicted with solely clinical measurable variables assisted school entry, which we all have been doing while trying to assess the children, be it considering the heredity, that is the parental association of myopia in the children, siblings, or the family, the baseline refraction, peripheral refraction, because the hyperopic defocus, as we have discussed before, can be a triggering factor for the cascade of the retinal signals to increase the axial length. The environmental factors near work, but more so the time spent outdoors, and the calculation of the biometric parameters like axial length, corneal power, lens thickness, lens power, etc., and the accommodation lag in these children. In view of this was the clear study group. Lisa A. Jones and et al. They further progressed with the study in August 2021, where they published the myopia progression as a function of the sex, age, and ethnicity of the children. And they found that younger children had faster progression of myopia, as we had documented earlier, if they started earlier with the myopia. For example, the model estimated a 3-year progression in Asian American children with minus 1.93 diopter when onset was at 7 years compared to 1.4 diopter when onset was at 10 years. So you can see here that the ethnicity, the age of the children mattered if the regarding the progression of myopia when the onset had actually happened. And the annual progression for girls was 0.093 faster than that for boys. So this also predicted regarding the gender predilection of this myopia progression. So ultimately, we can see that it is not the genetics, only the genetics that play a role, but the genetics and the environment and the epigenetics all have an interaction in the progression of myopia. So everything considered has to be taken into account as a risk factor or the causal factor for progression of myopia. So to conclude, we understand that the family, taking a family history for to understand the risk of children who are going into myopia, progression of myopia, the baseline refraction, be it complete cycloplegic refraction, peripheral refraction, if possible, should be undertaken. Biometric parameters during their follow-up, especially the axial length and the cornea and corneal topography or the tomography, the lens thickness and the lens parameters are to be included. Accommodation lag, if possible, has to be considered. And most importantly remains the environmental factors. Therefore, the question is for outdoor activities is to be included in understanding the risk factors for myopia progression in children. With that, I thank you all for giving me this opportunity.
Thank you, Dr. Deori, for that very clear and insightful overview of the various risk factors that influence myopia progression. You have very clearly highlighted how early age of onset, parental myopia, and various genetic and environmental factors can influence myopia progression. I would ask a very quick question to the panelists because we don't want to encroach upon the last speaker's time. The speaker mentioned that outdoor activity has a very good protective role against onset of myopia. Does the same protection also occur if the child already has developed myopia? Will it prevent progression of myopia as well? Dr. Ramesh, could you take that?
Yeah, I think once the myopia is already,
yeah,
I think once the myopia onset is already there,
yeah,
the role is very minimal.
right, sir.
Am I audible or not?
Yeah, Dr. K, you
It
are
tends
audible.
to.
Dr.
Okay.
Anand, your
Yes,
bandwidth is
yes,
low.
you're
If you can switch off your
audible.
video, I think you will be better audible, Dr. Anand. Dr. K, you
Dr.
can please
KR, you
continue.
are audible.
Okay. So my point was once the myopia is already there, then the chances of preventing the progression is not so much.
Yeah,
I will
sure.
not say it is less, but the outdoor activities has a significant role in even catching that train of myopia. Before that, if you really apply, it will be really good. They say that before 1000 days of a child's life, don't expose them to too much of a screen time. All these things are effective there. Basically, in one word, the protective effect, once the myopia is already there, it's not zero, it's available, but it's much more beneficial when the myopia is onset is already not there. That's all I wanted to say.
Great. So I think we are running short of time, and with that, we should move over to the next speaker, Dr. Aditya Sethi. He'll be speaking on genetics and epigenetics of myopia.
So Aditya is traveling and he is in US, so he sent a video.
Okay.
I will just play the video on his behalf.
I'm Dr. Aditya Sethi. I'm a consultant ophthalmologist. I do myopia refractive and pediatric ophthalmology. I would like to start my very interesting presentation with thanking Dr. Namrata Sharma, Dr. Jethani, and AIOC for giving me this opportunity. What we're going to talk about is myopia and genetics. And the question often asked is myopia written in our DNA or our lifestyle? And that's the question we hope we can answer today. So, happy good afternoon and happy Republic Day for everybody who's watching. Today we'll talk about myopia not as a refractive error but as a biological condition influenced by genetics, environment, and time. This is a topic that affects not just how we prescribe our glasses nowadays, but also how we think about prevention, counseling, and long-term dental health, which can often result in blindness later on. So why this matters is myopia is no longer a benign condition. Like our previous speakers have spoken about myopia being a global epidemic or a pandemic now. We're seeing unprecedented prevalence globally. There is a lot of literature which is supported that by 2050, which is not a lot of years ahead, nearly half the world may be myopic and about 10% highly myopic, leading to blindness with pathological myopia, this high 10%. This translates to a massive future burden of retinal detachments, myopic maculopathies, glaucoma, and CMV. So this talk is not about minus numbers, it's about disease risk that we should be all. This is a quick audience poll. This is something that we often ask to all our peers. Is what you think that drives myopia? Is it more genetics, environment, screens, or education? And I think we can all fairly agree that the correct answer is all of the above. It's not the factors, it's the key is how they interact with each other, which results in a myopia of what level. So again, the next question I would like to address is myopia genetic? Myopia is absolutely genetic, but not in the simple mandated way. In simple terms, it's not straightforward genetics which work here. So twin and family studies show heritability estimates of close to 60 to 80%, which is greatly substantial. With that high number of percentage says that definitely genetic. However, we have genome-wide studies which were game changers, and they tell us there is no single myopia gene. Instead, myopia is polygenic. Polygenic means hundreds of genes, which with small effects lead to larger results, which is myopia. So genetics determines susceptibility, not inevitability. So we may have some precursor genes, but the environment which triggers these genes make you more susceptible to myopia. So various papers are available who has open access as well. When we talk about next is the family history. And in our day-to-day clinical practice, this remains the strongest genetic marker for us as clinicians. Children with one myopic parent have 2 to 3-fold increased risk of having myopia. And where both the parents have myopia, the risk increases to up to 5 to 6 times. And these have been repeated in many studies over the years. Importantly, these children tend to develop myopia earlier and they progress faster when there's a history of myopia in the family. Family history captures both genetics and shared lifestyle, which is why it's so powerful and something that we depend on as clinicians. What does polygenic mean? When we say polygenic, think of height and not color blindness. A lot of genes, tiny effects being leading to myopia. No single gene causes myopia. Instead, hundreds of genetic variants each nudge eye growth slightly. When the nudges add to a cumulative score, especially in high-risk environment, myopia becomes clinically active. This explains why siblings in a similar genetic pool or and similar genetic environmental factors may have different refractive outcomes. Various landmark studies. We have the GWA studies, which really change how we think about this. And sort of, we all realized that myopia genetics is robust, reproducible, biologically plausible, but not a statistical coincidence. The various genes were studied, and we realized that some of them are triggering genes, and this is what helped us understand better about polygenic reasons for myopia. And I would recommend all of us go through all these studies to understand myopia slightly better. So, important pathways. We need to know what biology does do these genes affect. So genes are not acting on the cornea lens. They influence retinal neurotransmission, especially dopamine, which leads to visual signal processing, which also modifies the skeletal extracellular matrix by remodeling it, leads to axial length elongation, and that is a control that we must have to prevent myopia, and also circadian light signaling. This reframes myopia as a disorder of eye growth regulation, not optics. So it's basically a gene activation which causes remodeling of the eye, which causes axial elongation, and leading to myopia. So these are what the biology is leading to. There are certain important pathways we must understand that there's a crucial conceptual shift now. That visual input is processed at the retina, translates into biochemical signals, and then acts on the sclera to regulate axial length. So when we talk about myopia control, we are really talking about modulating a biological growth pathway. Now, when I talk about various genes and multiple genes, I must mention this hero gene, or the one gene which is repeated in most of the studies as consistently being replicated as being one of the most common affected genes in myopia, as GJB2, which is gap junction delta 2. It's involved in retinal signal transmission and links optical defocus biochemical signaling, which ends up with axial elongation. So in short, what we're trying to say is that the minus power is only the tip of the iceberg. It is basically axial length or axial elongation, which is the real disease. This is one of the most important slides of the entire presentation, where we're aiming at talking about how genetic studies show stronger association with axial length than with the refractive error itself. Axial elongation causes mechanical stretching of the retina and the choroid, and this is what explains why myopia increases the risk of maculopathies, retinal detachment, glaucoma, and CNV. Myopia is basically the symptom. Axial elongation is the disease. So why genetics alone cannot explain the epidemic? If myopia was purely genetic, prevalence would be stable across generations. Instead, we've seen an explosion in just about 30 to 40 years, especially in urban East Asia. Human genome has not changed that fast. So this tells us something else is activating these genetic risks that we have. And that, of course, could be the environment. So gene and environmental interaction can lead to this explosive increase in myopia now. So genes do not act in isolation. Their effect size changes depending on environment. Large data sets show that education intensity, how much we educate the child in a day or how many hours and what sort of environment the near work is done in and how much of near work is done in, the reduced outdoor time amplify the genetic effects. I like this phrase, genetics sets the risk ceiling. Environment determines how fast we reach it. So that's something that makes a lot of sense to me. Outdoor time. This has been spoken about before as well, but I just want to touch on this. This is one of the most reassuring findings in myopic research. Randomized controlled trials have shown that increased outdoor time reduces the incidence of myopia and slows progression, even in genetically at-risk children. Bright light increases retinal dopamine, which acts as a brake on axial elongation. Genes do not cancel sunlight, which is great. Next, we're going to talk about something very, very important, is epigenetics. So this is same genes and different outcomes. That's why siblings can have a different myopia. This actually helps explain what we often see in our bodies, that siblings with same parents but very different refractive outcomes. So epigenetics refers to changes in gene expression without altering DNA sequence. Environmental exposures like light, near work, screens can switch growth-related genes on or off. Genes produce and provide the blueprint. Epigenetics basically decides how it will need it or how it's led. So in simple terms, it's the fine lining in between. Many scientific reports have been there which talk about how epigenetics, what modification can lead to different phenotypes. So high myopia. So we understand not all myopia is equal. High myopia carries a stronger genetic signal, earlier onset and faster progression. Environmental modification alone may not be sufficient in these children. These are the patients where early structured and myopia control is critical, especially to the outcome of how high the myopia will be. So next question is, can we predict myopia genetically? So polygenic risk scores, that's the PRS, are exciting from a research standpoint. They combine hundreds of variants into a single risk estimate. However, they are not clinic ready yet. Ethnic variability, environmental override limit individual prediction. For now, PRS is the risk thermometer, not a diagnosis or treatment plan. So it's still under the works. So what does this mean in the clinic? You don't need genetic testing to identify high-risk children. Early onset parental myopia, rapid progression, sibling myopia, and outdoor exposure already tells you who is genetically loaded. These children should not be observed. They deserve early intervention as early as possible. Next part is counseling the parents. And this slide is all about the language. Often when we say it's genetic, nothing can be done, we create helplessness, panic, and blame. If we say your child has a higher risk and we can modify it, we empower the families. So we are protecting the retina, not chasing the zero power. That is the underlying of what we need to understand. Now coming to the big picture, myopia develops through interaction of genetics, environment, and time. Early onset means longer exposure, higher lifetime risk. That is why early intervention matters so much. What my take-home message would be that myopia is polygenic and biological. Genetic influences axial length. Environment modifies risk. Outdoor time works. High myopia is different. Early action in all these cases changes the outcome. If you take that, I think we've been on the same page. Final thoughts, I'll end with this. We cannot change a child's genes, but we can change how those genes behave. That is the real power of understanding myopia genetics. Thank you so much for patient hearing, and I hope this presentation throws a little more light on genetics and epigenetics of myopia. Thank you.
Thank you, Dr. Jitendra, for displaying that video. It was indeed very well covered. And I really like last couple of slides where how the genetics and epigenetics of myopia help us in our clinic. Multiple pathways, numerous neurotransmitters, and multiple genes. It is all good to know the science behind the myopia, but in the clinic, I think with the strong history of single parent or both parents having myopia, the onset and all those things, I think they are the deciding factors to drive. Also, another thing in the clinic, what we see, what Dr. Aditya also mentioned in one of the last slides about the counseling. So we have seen that if both parents are there, if mother is myopic, especially in our socio-cultural scenario, it can become a issue. Just if parents ask that is it genetic, and that can start as a blame game or kind of to show that okay, one parent is responsible if not both are myopic. So in that case, as a clinician, we also should understand how to deal with those questions, which can have some socio-cultural effects, after effects. So I would want to ask panelists their thoughts on the genetics and epigenetics of myopia.
I think we would like to have a quick comment from Dr. Siddharth. He has just joined. Dr. Siddharth, your comments on genetics and myopia. He actually
thanks,
wonderful
Jitendra, and
lecture on genetics and myopia at AIUS. That was
thanks,
really nice.
Jitendra, for referring to that talk. And I'm very sorry I could not join earlier. But the talk by Dr. Aditya Sethi was very good. And a few things that he has covered about myopia being polygenic is true. So earlier in older studies, we were studying higher myopia. So myopia which was pathological, which was clustering in families. And we are trying to find out a common gene, which is either autosomal dominant or recessive or X-linked, and follows a Mendelian pattern of inheritance. And then we had around, a few genes which we called as MIP1, MIP2, MIP3 genes. But always the genetic background of your simple or school myopia was elusive. And no single gene could be attributed and did not seem to follow Mendelian inheritance, because the children of the same parents, they had different degrees of myopia. Some had myopia, some didn't have myopia, some had myopia only in one eye, and all these myopias didn't seem to have a single gene this thing. So for a very long time, simple myopia, the genetic basis, we used to always say it is polygenic, but there was no way to find out which are the genes. And then these genome-wide association scans came when a lot of companies started collecting DNAs of populations, entire populations, and then they started putting, each variable, like myopia being a variable, and then they separated the population into people with myopia and without myopia, and then they ran a statistical analysis to find out what are the common genes in the myopic patients. And then they try to find the statistical significance to the level of 10 into minus 8, that is 1 billionth chance of having it as a, by chance, that gene being common in this group. And that's why all these genes are actually single nucleotide polymorphisms. They are single nucleotides being changed. And they need not occur within the known genes. It is occurring inside the entire genome. And till date, when you combine all these studies together, the ones done in UK and Europe and even in America and these private companies, you have almost 500 single nucleotide polymorphisms. Now, to complicate matters, when you put a polygenic risk score to all these genes, that means you try to see if you have a bunch of these genes in an individual, what is his risk? You are still only able to explain only 11% of the variability of myopia in the population. So that means it is still far from being able to predict myopia. Still, you can predict myopia better on cycloplegic refraction at a younger age. That has got a higher predictive value than doing a genomic analysis and then trying to put a polygenic least score. But eventually, that is the idea. When you have enough data, you will have enough number of genes which you will suspect And if you have a large pool of these genes, then you can say, okay, if you have like 500, I mean, you have 200 of these 500 genes, then you have a 50% chance of developing myopia. Now, these genes are arrived as, they are actually statistically arrived at, and you don't know their function. So you just happen to find them in this population, but you don't know how it acts. But the interesting part is many of these genes occur very close or in the vicinity of candidate genes. Now, what are candidate genes? Candidate genes are genes with known functions that you have already mapped. And you are trying to see whether, like, suppose intuitively thinking, if axial length is there, then you will always try to study the genes around collagen or, or the extracellular matrix. And if you know the gene associated with collagen, and then you get these SMPs which are clustered around these collagen genes, then you know that it is affecting the collagen pathway or the laying down of collagen per se, or the laying down of glycosamine glycans or extracellular matrix. That's why this field is extremely exciting now, and every few months you have another bunch of genes coming. It is unbelievable that from 1980s to say 2010 or something, we had only like 10 or 12 genes known with myopia, and today we have around 500 genes known to myopia. Also, one thing which is very exciting is when we are trying to find out the effect of treatment on children with a particular set of genes. So it's been shown that there was a small study in Spain where they did a pilot study and tried to find out whether a particular variation of a gene was associated with a higher response to a particular lens. So, even that, the treatment effect may be dependent on your genes. Intuitively, yes, but it needs to be proven. So that's where probably we could explain the variability, that why some children don't respond to atropine and some children don't respond to glasses. And so maybe it's in their gene probably. And then if you can tailor make it according to their genomic analysis, then it would be great. But again, that is all in the distant horizon. But I can for sure, I even said this in AIOS, that today we are measuring the biometrics of a child and we are trying to, find out their lifestyle patterns. In 10 years' time, the first thing you will do is, when the child is born, you will do his genomics. And then you will have a list of diseases that he's likely to suffer and what you should do in his lifetime to do that. And that's a very exciting area.
So that's pretty interesting. That sums up the whole experience of genes and myopia. I think we would be around when all this happens. So
Sure.
so just a quick information that there will be MCQs, and if you can listen to these talks at least 75% of them, and if you can attempt, or rather if you are right in those attempting those MCQs, 70% or 75% score, the link is there in the chat box, webconnect.in AIOS myopia module. You can get certified as a person who has attended this myopia progression module. So just wanted to inform the attendees. Please carry on.
Dr. Jitendra, if you can also tell how long the link will be active until when they can answer those MCQs.
It will be active for quite a while, sir. Even after they can attend.
Sure. Great.
So
Right. So I think that was a wonderful session and perfect opening session for the next things to come. And I hope all the attendees got to learn a lot, just like myself. And we're looking forward to the next few sessions on management of myopia. Once again, I thank all the speakers, Dr. Pranav, Dr. Neelam, Dr. Niluparna, and Dr. Aditya, and the expert panelists, Dr. Ramesh, Dr. Siddharth, and Dr. Love. And finally, I would thank AIOS Chairman Scientific Committee, Dr. Namrata Sharma, and of course the course director, Dr. Jitendra Jethani, to put module on management of myopia. Thank you all for joining us on holiday afternoon. Thanks and hope to see you again soon.
So the
Thank you so much, everyone.
next session will be
Thank
on
you, sir.
Thursday at 2:30, and it will always be on Mondays and Thursdays in the afternoon. And the links will be there. Links will be provided. You can register based on the email. They will send you an email with the links, and they've already sent or uploaded the link. So thank you, everybody. Thank you, the moderators, Dr. Anand, Dr. Ajinka, and thank you all the speakers to gear up at such a short notice. Thank you so much.